Okay, so I've been asked to talk about a relatively new area that's developing, which is the role of multiparametric MRI in active surveillance. These are my disclosures. So when we have patients, there are two strategies one can use for surveying patients and not treating them straight away. And the first one is called active surveillance, and the other one is called watchful waiting. The active surveillance strategy is used for patients with low-risk disease. So in other words, they have to have Gleason 3+3 and low-volume disease and low PSA. Now, you notice the emphasis was on and, right? So all three criteria have to be met. The idea here is to prevent overtreatment. There are some Gleason 3+4 cancers who will also be suitable for active surveillance. And these are increasingly being incorporated into new clinical trials. So you need to know about this. And the idea here is not to avoid treatment, but to delay treatment for the appropriate patient. Now, this is very different from watchful waiting, where the intention is not to treat until complications occur and when the intention is to palliate. Okay, so here's a very typical example of somebody with a bladder carcinoma. You can see there are lymph nodes in the pelvic side wall. There are these abnormalities here, and you know the patient is on active surveillance. So in this particular instance, we elected not to treat the prostate cancer because he had metastatic disease already in the retroperitoneal lymph node. So a typical watchful waiting patient. Now, how common is this? Well, it turns out it's about 1/3 of all the prostate cancers diagnosed. So in the United States, that is 100,000 patients. Now, how many of these people had radical prostatectomy that's going to not kill them, right? So there's a 3% chance that these patients will die from prostate cancer. What do you think is the proportion who had prostatectomies? You'll be surprised that it's 70 to 80%. So 80,000 people having prostatectomies for cancers that won't kill them. Now, you have to say, well, why is that? Well, we could say it's greedy urologists, but it isn't, you see. It isn't. The problem is that urologists know that the way they diagnose patients leaves aggressive tumor behind, even when they think the patient has low-risk disease. So here are 12,000 prostatectomy specimens in low-risk disease. And if you look at the pathology, you'll see they've had decent trust core biopsies. You can see that the prevalence, for example, of Gleason 7 or above is actually quite high, 25%. Organ confinement, only 77%. In other words, about 25% have extracapsular disease. And this has been shown repeatedly again and again. So they don't trust their finger, they don't trust their PSA, etc., etc. The other problem is men don't accept active surveillance for cancer because they think it's doing nothing. And most men will not accept that. So there's a social attitude there. And what you have to remember is this is quite a rigorous process. So if you are a man on active surveillance, you get PSAs and DREs every 3 months for 2 years. So that's 6 visits. Then every 6 months for the rest of your life. So hang on. Somebody's going to stick a finger up my bottom every year until the day I die, right? Okay, then you need a biopsy at year 1, in my center, year 1, year 3, and year 7. Some, if you're in America, they repeat the same biopsy, they've done a trust biopsy, they repeat a trust biopsy again instantly, and then one a year later. So in 1 year, you end up with 3 biopsies. Each of them is 12 cores. That's 36 needles in 1 year. So why would you do this? Doesn't make any sense, right? So men get fed up with this also. And of course, the problem is nobody can agree on what is the eligibility criteria. So if you look at these large studies that are going on, you'll see that Johns Hopkins does not let anybody through unless they are very, very low risk. Whereas the Royal Marsden lets anybody through, right, even with large volume disease. And so there's a problem there. So there is quite a lot of variation about who goes into these large clinical trials. So the challenges are that we are over overdiagnosing and overtreatment. We know that we are under staging, that nobody can agree on who goes in, how often they go in, how often you do it, why they come out. The biggest problem has been we don't know what the long-term outcomes are. It's only now, with this Klotz article published at the end of last year, that there was like a 15-year follow-up to show that actually it's a safe thing to do. So now this is becoming more accepted. So what can we do about this? Well, there's a number of things we can do. We have some very powerful tools. The first thing we can do is stop diagnosing low-risk disease. Right? So if you use targeted biopsies, you decrease the rate of low-risk disease diagnosis, so that we can do that. We can characterize those patients who are going to go onto active surveillance and say, this guy is suitable, this guy is not suitable. We can also follow these patients in time and say, this guy is changing, take him off, this guy is changing, reassess him. So there's a number of things we can do. Okay? So the first thing we can do is stop diagnosing prostate cancer. So if we just did targeted biopsies after MRI and not trust biopsies, that would reduce the prevalence, the incidence of the diagnosis of low-grade disease by half. Don't diagnose these patients. First answer. Now, what about patients already in active surveillance? They're coming to you. What should you look for? Well, you look for anything that's bad. If something looks bad, either on T2, on diffusion, on dynamic, on spectroscopy, on a PIRAD score, on a Likert score, it doesn't matter. If it's bad, it's bad. And this is the message. So if you look at this, this is a systematic analysis that was published a couple of years ago, well, no, last year. All they did was say, was there a lesion there or not? Did you see anything there? Now, if you did that, you notice that about 3/4 of men have a lesion that's consistent with cancer. If you have a lesion, then 1 in every 3 to 4 men will become reclassified as to a higher risk cancer. So all you have to do is say, can I see there's a cancer there? And if you say yes, then there's a probability of 1 in 3 or 1 in 4 that that is a bad cancer. See, just have to look at the picture. Or you can do a bit more, you can put an ROI. Put a simple ROI and say, what is the measurement? If your measurement is more than 1,000, then you're going to do better than if you're less than 1,000. Your treatment-free survival will be better if your PSA is more than 1,000. Now, we did the same thing, looking at 150 men, and this time, all we did was say, how good is PIRADS? And you know what? It works. If you have a PIRADS 1, 2, or 3, that is the treatment-free survival. If you are 4 or 5, that's your treatment-free survival. And we've followed up to 5 years. You can see this is 60 months here, right? And this is 1 year experience, and 4 years experience. So you don't have to be an expert at this. You just need to know how to read prostate MRI. If it looks bad, it's going to be bad. That's the message. Okay? So does this look bad? No. You can't see a lesion. This is a PIRADS 1 or 2, whatever you want to call it. Doesn't matter. This patient's doing fine. 7 years he's had on follow-up. What about this one? Now, this is a problem, isn't it? So you have a lesion, less than 1 centimeter, apical. This is borderline. So you may want to try. He has actually been on active surveillance for 6 years. His PSA is now just rising. But look how old is he? 78. So that's when he started, right? He's now 85, right? So actually, you've done your job for what was a borderline lesion. What about this? Well, clearly, this guy is not suitable. So this is your red flag saying, please don't do this, right? There's an anterior lesion that you've missed, okay? So this guy went off active surveillance. All right. The problem is this. So here's a guy who came along, looks like he could go into active surveillance. Here's a lesion, anteriorly clearly missed, rebiopsied with a targeted core, 9 millimeters. So he could have stayed on. He's borderline still, but he elected to go off. And he had cyberknife radiotherapy for this. Now, clearly, this was a big mistake by the finger, correct? Big T3 disease, supposed to be suitable, clearly not suitable, has large volume extracapsular disease. Here's another patient with an apical mass, clearly showing some extracapsular disease, very, very low ADC. Yes, less than 1,000, even you can see that. This patient should not be on active surveillance, but came in, query suitability. Now, can we do more than that? Of course we can. Now, remember, if your PSA is 10.1, you are no longer low risk. You are actually intermediate risk. Hang on a minute. 10 versus 10.1, you completely shift your risk. Does this make sense? No, of course it doesn't make sense, right? Now, it turns out that if you have intermediate risk prostate cancer and your PSA is between 10 and 20, your outcomes are the same as active surveillance. There's large amounts of literature showing that. So if you only have one risk factor that's above the PSA, you are actually quite suitable for active surveillance. So what you have to do is to identify if that patient is actually suitable for active surveillance. So here's an example. So this guy has 3+3, look, 5% of cause on right and left, so suitable for active surveillance. This was the only risk factor. Can you see? It's now 24. It's more than 20. It's not just 10.1. So you know there's a rat here. Okay? You know there's a rat. You need to find the rat, and you can see the rat is in the front, a big anterior tumor. So there are some patients in whom they are just creeping into the intermediate risk category, and MRI can actually be quite useful. Now, 3+4 disease is interesting, because one of the things I said is increasingly being used in some protocols. Now, it turns out that if you take 3+4 disease and you do a prostatectomy, it turns out that 10% in the end are 3+3. So they came in for a prostatectomy of 3+4, you take the prostate out, and it was 3+3. Right? It's about 10%, between 8 and 12% if you look in the literature. Now, you can find those people, right? So if you have something like this, 3+4 disease on a TERP, you can see it there, right? No index lesion. You should suggest that this patient undergo active surveillance, not active treatment. Because you pull this guy out from treatment and you put him into active surveillance. This is exactly what we did. So we rebiopsied this peripheral zone. Again, it was 3+4, small volume disease. He's now undergone 3 follow-up scans, and he's still doing fine. Okay? So these are the people that you can do. Now, some of you will say, anecdotal case, give me some evidence. Of course. Now, here is 304 patients that were looked at Memorial Sloan Kettering. In fact, there's another paper that's just been published, almost the same number of patients. Essentially, if you see nothing, in other words, it looks like a clean gland, but there's 3+4 disease, you should suggest active treatment. No, you should suggest active surveillance, okay? Because these 3+4s will actually turn out to be 3+3s. Right? So this is another group you can move from one bucket into another bucket, okay? Now, the other question that always comes up is, do I need my first-year biopsy? Right? Now, this is a difficult call, very difficult call. Now, so we can't really go through the data at the moment, but bottom line is this. If you have a negative MRI at baseline and you have a 1-year follow-up and you have a negative MRI at the end of it, so PIRADS 1, PIRADS 2, PIRADS 1, PIRADS 2, and you have a year, then the negative predictive value of that is huge. It's more than 95% because you've had 2 negative MRIs plus a follow-up period. These people can probably avoid a biopsy, the first-year biopsy. However, if you have a positive MRI, right, and you've had the interval follow-up, then the chances of you still harboring clinically significant disease is still there. You still need a biopsy. But we would then, in our center, recommend a targeted biopsy rather than a random biopsy. So that's how we tend to think up through these things. Now, when you follow patients over time, there are a number of observations that you will see. So you can have a small tumor that grows over time. You can have an abnormality that disappears. You can have a new lesion that appears. You can have a lesion that gets bigger and bigger and bigger. You can see extracapsular disease. You can see quite a lot of things. Let me just show you some examples. So here is a patient in whom all we saw was hyperemia in the peripheral zone on the 4th follow-up scan. Now this is related to biopsy. This patient has now undergone 8 follow-up scans and is still on active surveillance, still doing fine. So the things that change may not necessarily be due to cancer. Here's another patient. Now what do you think about this? So if you look in the peripheral zone here, you'll see there is a new abnormality here. Compare that to the baseline, you can see that. And you can see new hyperemia here. Now that too resolved subsequently. We've just looked at him again. That abnormality is no longer there. And Giuseppe read that case with me, right? So hang on. So this is probably prostatitis. You see these changes occurring, disappearing, occurring, disappearing. Now this is very different. And here's another example of the same thing. Look at this PZ. Look at this PZ. This is about a year apart. Look. And this is because of the bladder catheter, right? So benign things will cause changes. So you need to be careful when you see. Don't call every change malignant. Okay. Now, look at this. This is really subtle. Here is a patient with a peripheral zone carcinoma at the base. Here's the PZ here. Look at it over here. See, there's a slight increase in bulge. Now, I didn't see that increase in bulge. I did not see it. But what I did see was this light bulb sign. The DCE went boom, and I went, uh-oh, what's that? Right? That's what I concentrated on. So you see, this is a functional change, not much of a morphological change. We rebiopsied that area, targeted it. It was 3 + 4. We did a prostatectomy, and you know what it was? 4 + 5 + 3, T3A disease. Right? So you see a change on anything, you should consider re-evaluating the risk. Now, this is a cancer that's, you see, look at that. So you can see the cancer is getting bigger. And I'm saying, why are we doing active surveillance on this patient? It doesn't make sense. This tumor is growing. Why are we still doing this? Because the patient wants it. And I'm going, this is crazy. So here we go. From here, look what happens to the DCE. It becomes more and more positive on the early subtraction image. So in the end, I said, I don't want to see this guy again because this is crazy. And they took him off. And he's had I think he had radiotherapy for this. Okay, what about this? This is another example. See how this lesion here gets bigger and bigger and bigger, but nothing else seems to change. So this is a morphological change with the same functional characteristic. Now, here's an example of a lesion that went away. Now, look, there's a mass. There's a mass a year later. There's a mass another year later. Oh, what happened here? Disappeared. Hang on. And then the year after that, not there. The year after that, not there. And we've now reviewed him several more times, and it's not there. So was this cancer? It was probably mass-forming prostatitis, which just resolved over time. So benign things will go away. Malignant things will appear. Be careful. Right. So there's a lot of information in this. The question is, how do you communicate this to you? The way to communicate is use the PIRAD system because it works, right? Draw a diagram, give it a score, measure the lesion size, maybe even measure the ADC, and say, do you think this patient is suitable for active surveillance? Is this patient suitable for continued active surveillance? And it's very simple. So here's a patient. You can see there's a lesion here that goes away. Yeah, so this is probably hemorrhage that is now resolved a year later. So how do you indicate that? Well, it's very simple. You draw a diagram, a pen and paper, and then to get it into your PAC system, you scan it and you put it into your PAC system. It's very simple. It's not high tech, right? We're a health constraint organization. We just use a piece of paper, right? And it works. Now, the question is there a systematic way of capturing the changing data? Now, that's the new question. Now, there's something called the PRECISE group, which many of you will not have heard of. So the PRECISE group is come together and said, okay, we need to look at AS patients on serial follow-up and somehow categorize the changes in a Likert-like scale. So the Likert scale is over here. There are two proposals, one which is mostly morphologically based. So if patients change from these groups into another group, that is considered a change. So you will never see almost an increasing tumor size going to extracapsular disease. If you see that, actually you're not doing your job very well previously, right? So this is a morphological criterion which we think is going to have slightly less dynamic range. There is another proposal on the table which is morphology and function based. And that looks not only at morphological changes but also changes in the ADC value, in the DC, etc., etc. Now, I suspect that that has got too much dynamic range. It'll be too sensitive. So, for example, the prostatitis I showed you, it may have too much of that. So we don't know where this is going to be. So this is going to be the new challenge that we are going to have to get experience on going forwards. So what do the guidelines say? The guidelines say do multiparametric MRI before enrollment into active surveillance. So we would recommend it. It seems to work. We would recommend it. Redo it, not necessarily annually, right? The guidelines say when there is clinical concern, right? If you're going to do it regularly, you probably don't need to do it for more than 3 or 4 years. If you're 3 or 4 years, then most of the people that are going to declare themselves as being aggressive will probably already have declared themselves. Okay, so the summary is here. So multiparametric MRI can increase the precision of patient selection. I don't think there's any doubt about it. The guidelines accept it. You should do it. This is your job. The question is, which combination of features best predicts for treatment-free survival? We're not completely certain. It may just be a lesion that you can see. It may be the PIRAD score, something as simple as that. If it is, that'll be great, right? Because all of us can do that. Okay. If you see a change in the phenotype, don't assume that this change in phenotype is cancer, because it may not be. I've shown you a number of examples of inflammation, biopsy, etc., etc. So if you see a change, and you will see a change in about 50 to 60% of patients if you follow them over time, it's going to be quite a high number. You should suggest either a follow-up if you think it's going to be inflammation, or a reassessment of the risk profile of that patient. Okay? Clearly, if you're going to do this if you're going to undertake this work, then the communication with your physician is the most important thing. And this is exactly where I concur with Bernd. We need to have a communication in a structured reporting format which they can understand. Thank you very much.